Welcome to Dementia Air, a content channel devoted solely to exploring topics related to dementia. Dementia Air is a production of Beyond Dementia Coalition, a not-for-profit 501c3 which seeks to reduce stigma and help all of us not only recognize but also accept, assist, and embrace people living with dementia as valued and beloved members of the community. See the person beyond the disease. My name is Bruce Leyton, and I'm your Dementia Air podcast host. And with me today is Libby Dunahoo, Manager Advanced Care Planning at Northeast Georgia Health System. Today we'll be talking about making choices in the context of advanced healthcare planning. I always want to call it advanced healthcare planning, which I'm certain it is, but it's also advanced healthcare planning, which to me, Libby, says we're making choices for a future event. Does
Exactly.
does it make sense in teeing it up? So I'm glad I stumbled over it. It gave us a chance to talk about it. So Libby, let's start with, if it's okay with you, how did you find your way to NGHS, Northeast Georgia Health System? And perhaps you can tell us something about your work at Northeast Georgia Health System as well, just to get started.
Sure, I'd love to. I was fortunate enough. I have a background in development. I worked at Emory in affiliations, and then I was a director of development in the adoption world. And so when Northeast Georgia was looking for development for a new advanced care planning program, they were looking for someone that had developed experience. And I was fortunate enough to get the job when they were just implementing the Respecting Choices contract with the La Crosse, Wisconsin team at Gunderson. So they were the gold star program around advanced care planning. They were doing things that nobody else was doing because the point of it was that they realized that all health systems are required to ask people if they have an advance directive. It's part of our accreditation process. The problem was coming in that when people are in a crisis, either they don't know what it is, they haven't done it, they don't think about doing it. There were so many things that were barriers to people having advance directives that they were like, okay, if this is important and we're seeing that it's important, how do we help people start talking about this upstream from a crisis? And so that's really where the development and the community side came in, of saying we actually need to normalize a conversation around death, which is, people think of that as a very morbid topic, but it's also a reality. And the reason we're not prepared to advocate for someone that we love, and what we're really doing is that we're not advocating for death, we're advocating for life and the best quality of life that we can afford, whatever person is walking through their own healthcare journey. And so empowering people to do that has become the focus of this program. And what we saw they did so well in La Crosse, Wisconsin, that we wanted to be able to implement that here. So I was fortunate enough to be hired to implement that contract here.
And so in your brochures, I've seen you mention person-centered care. How does that play into what you've just shared with us? I know we talk often about caregiving and healthcare, about person-centered care, but would you elaborate on what that really means in the context of advanced planning?
Well, and that's exactly the need for healthcare. So often has been that you are your disease when you're in the hospital. You are a cancer patient. You are a heart failure patient. But every person is more than that. So healthcare has even had to adjust and say, we need to be sure that we're offering person-centered care. Who is this person, and how do their goals and their preferences and their values actually end up guide clinical decision making? So everybody has, and a good example is our Jehovah Witness population. They have done a great job of saying what they feel is important for them in their healthcare. And it's their goals and their preferences and their values, and it guides their clinical decisions that they say, we know why we believe this, we know what we don't want, and what we do want within healthcare, and we want to be sure those things are followed. So we really appreciate that it gives us the guide for how them as a whole person and how their faith completely guides their clinical decisions. We need everybody to do that. It doesn't just have to be a faith decision. It can be a decision about your goals in life. Someone might be a cancer patient, but they're more than a cancer patient. As whole person centered care, you say, what treatment options do you have and how are they affecting your goals in life? Are you wanting to travel? Are your choices around your chemo choices affecting your living? Are you paying for treatment that is affecting your ability to pay for food? Are you choosing a treatment that's requiring transportation 3 days a week somewhere for infusion or for dialysis? And how is that affecting you as a person? It's not just that when you come to the hospital that we're offering a clinical treatment goal. We're integrating that with who you are as a whole person. And we want to be sure that we hear those things that guide that so that it goes back to empowering the patient to advocating for quality of life and how healthcare is integrated into that quality.
I hear you talk. Let's walk down the road. I've got a ton of questions for you, but let's walk down the road just a little bit. Say we've embraced all that in terms of making the choices that are person-centered and the reasons why and the dynamics of it to some extent. But there's also when we get later on and we're confronted with the choices we've made as a family, as someone who's put together their advanced directives, there's also the emotion that enters into it in the middle of disease, in the middle of end of life and everything that happens there. And I know when my mom passed, all of a sudden we were faced with creating a POLST, POLST, and maybe you can tell more about that as a document, and also how does it actually play out in reality in terms of the directives and the POLST and the emotions that take place at the time that those choices come to play. Choices you might have made a while back, but where kind of the dynamics, maybe family dynamics, take place. Does that make sense? Is that a decent question?
Yes. Yes, because that's actually it's where, basically the rubber meets the road. This is when decisions become actions. And that's hard. And so what we do is we talk about advanced care planning and PULSE, physician order for life-sustaining treatment, in a sense of when you move a conversation upstream, you're learning how to advocate for someone that you love, right? You're saying, what is quality of life to me? When would I want certain kinds of treatments and when would I not? And we're talking about life sustaining treatments. We're saying, this is different from therapeutic care. And so that's part of understanding how to advocate for someone. Are they saying, I wouldn't want to live on a ventilator with a tube down my throat if I don't know who I am, where I am, or who I'm with? But if I have pneumonia and I can be intubated on a ventilator and I'm getting better, and then that's a difference of therapeutic care versus life sustaining care. But what the bigger piece is what you're talking about, where the person that's the caregiver, the person that's named as a healthcare agent in an advance directive, has to actually carry out these wishes into actions. And that's where advocacy is having to remember that you do have to make decisions in difficult times and you're making them for your loved one wishes, not for your own heart. And that's difficult because someone could be saying, I wouldn't want these certain life sustaining treatments, but the person that has to enact it has to then say, okay, then they're saying, I'm going to be making the decision to let them go. And that is a hard thing. We're not alleviating the grief of loss. But what we do is when you have conversations with the people that you love, when it does come time to enact them, you have their words in your head. You're sitting there remembering that conversation. Too often we do see family that struggles with people saying, no, 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 don't let her go. And someone else saying, but this isn't what she wanted. And she wouldn't want this treatment. And this isn't going to provide quality for her. It's just going to have us hold on to her. But other folks in the family are saying, but I don't want to let her go. And the reminder has to be, but is this about us or is this about her? And that's what we do see families in distress. We do see how difficult it is to carry out actions. But the people that have the ability to do it are the ones that have had good conversations and that have said, I heard her say this would not be quality to her. So now I'm doing this based off of what I want versus what she would want. So to me, that's the bigger piece in advanced care planning is not just hearing what your loved one would want, but being able to have that conversation with everybody that is going to be involved that says, this is going to be hard. If you're having to make decisions for me because I'm not able to, I know it's going to be hard, but please remember this conversation and it's about being ready to let people go when they want to let go. And so the PULSE, the physician order for life sustaining treatment, is the step beyond an advance directive. An advance directive, like you mentioned earlier, is looking in advance for situations that you can't foresee. We don't know what's going to take us to the hospital. We don't know when we could be in a situation where someone's having to make decisions for us. NGHS is a level 1 trauma center. We see people every day where families making decisions they weren't intending, knew that they were going to have to make for their loved one. But the PULSE then becomes for people that are dealing with more long-term disease like Alzheimer's or dementia. And before someone loses the ability to speak and have these conversations, it allows you to say, let's go ahead and talk about life-sustaining treatment options like intubation and CPR and feeding tubes and antibiotics and things like that that could end up affecting someone's quality of life. You can do a pulse with a physician because it's the same conversation a physician has when anybody is in the hospital about their code status and if their heart stopped, what would you want done? And there's people that say, at this point, I wouldn't want that anymore because there is a tipping point at which CPR becomes more harmful than helpful. So therefore, it allows people that do have a brain degenerative disease to have these conversations with their physician in their doctor's office while they're seeing their neurologist well in advance, instant can have a conversation, or even if the patient themselves are beyond that, their authorized person can have that conversation with the physician and say, I know we did have conversations before they lost this ability, and I know they wouldn't want these things. And it allows them to put that in a document. At the same time, for people, for other folks, it's really only for people that are considered in their last year of life that a physician would do this. So it's not something that people are choosing early to be a DNR. Some people confuse it with other choices going on around assisted medical assistance in dying, and that's not what a PULSE is. It is specifically around life-sustaining treatment for someone that's in their last year of life. But the exception I do like is made for people with dementia because it can be such a long road before someone has the ability to speak for themselves that they're still dealing with this disease.
Thank you for that. I have one last question. It's maybe a little complex, but I think we ought to include it in our discussion today. And that goes to the respecting choices part of the discussion and choosing a healthcare agent. So you've talked about the responsibilities of a healthcare agent as advocate, but how do you get to who can I trust? Who has the emotional IQ? And who do I think, if I'm actually creating the advanced directives, who can I trust to really be an advocate for me? Is there any way to measure that, or is it intuitive? And I'm just thinking about what happened, with my situation. I'm thinking about what might happen with my three daughters down the road. Should they need to exercise, my advanced directives? Just wondering if you can answer those questions.
Well, part of what we have listed in our advance directive is what makes a good person that you choose as a healthcare agent. They have to be someone over 18, but we talk about it needs to be able to be someone that you trust and someone that can make decisions in difficult times and someone that can honor your wishes, even if they don't agree with them. So when I talk to folks, I try to encourage what those things mean. It means that you have more than one. This is not a one and done conversation. This is something that you sit down, and I've talked to my boys all together, and I can start to see as we have questions and we talk back and forth, I can see and I kind of intuitively know which ones struggle with the thought of following my wishes and which ones are like, okay, if that's what you want. But being able to have conversations and like I said, have them more than once, it kind of helps shape that because you can start to say, I know that you're going to have trouble with this, and I want you to grieve me a lot when I'm gone. But this is, and so having them hear it together, kind of, working through and acknowledging that it's decisions in difficult times. I always say that just because you've had conversations doesn't mean that you're alleviating that it's going to be difficult, but really leaning into that and saying, I love you guys so dearly. I want you to hear me say this so that when you are grieving that you're having to make these decisions, that you can support each other in this. But I think it's hearing that together because so often the biggest thing we hear is families saying, we've never talked about this. And that becomes them guessing for mom or dad. Well, I think she would want this. Well, I don't think she would. Or again, that emotional, I can't make this decision. I just want to keep holding on. The more conversation you can have and the more you can acknowledge the truth about situations. I think that even we've had families that have said, you know what, I truly don't think that I've talked with my daughter and wife, and I don't think they can do this. And I'm actually choosing a close family friend of mine. Sometimes people would go, oh, you're not going to let your family, but they have talked through it with their family and said, I see that they're going to struggle with this and I'm going to give this decision making. But I would never encourage anybody to do that and remove that authority from family without conversation because it is an emotional time. And if you really take that out of it, you're not preparing people honestly. And so to me, it's always the biggest thing that I see people lean on when they're making these decisions is they lean on conversations they've had in person. And it can't be one conversation is going to cover everything. It should be conversations as you watch a TV show, as you watch a movie, or find out, have friends. Everybody has people around them that are going through situations. And I constantly tell people, talk about what are your fears? What are your own personal experiences? Because people make decisions based off of what they've experienced. So if someone in their family has had a bad death, they will end up having a fear of having that kind of death. And so that conversation becomes so important. I saw my mom go through this, and I don't want to have to see you guys deal with that. I saw, so when we are seeing friends and loved ones and people that are, friends or acquaintances in our life go through things, bring that back and talk to your own family and your own loved ones and say, I just saw this on TV. I just saw this happen with so and so down the street. Man, I loved how they were able to, as Gordon Sawyer says on our videos that are on our website, his family said, we were able to walk the path he set because they relied on conversations that they had with him, that they were able to act on his wishes versus other people that tell me, I don't speak to my sibling because we did disagree about dad's care. And so they don't have any peace. Both of them are grieving the loss of someone, but some people have a peace in the decisions for honoring their loved one, and other people have no peace. So the grief is always going to be there, but I think that the sense of peace comes from the more you've talked about how do we on her wishes about what her fears were or what experiences she saw in other people. And I think one of the greatest conversations you can have with your girls is exactly what happened with your brothers. So that becomes something that will benefit them down the road when one day they are making decisions.
Yeah. Thank you for that. In closing, first of all, I want to thank you. And second of all, when I did my paperwork, and I'll call it paperwork right now, is that I saw it as a legal matter and whereby my choices would be exercised at a point in time by somebody else. But it's not really about a point in time. It's really about our humanity, isn't it? Our life experience, our emotions, our identity. And
Exactly.
you've brought that to life today. Thank you so much for being with us, Libby, and hope to talk again soon.
Thank you so much. I appreciate it, Bruce.
Beyond Dementia Coalition is on a quest to close the dementia preparedness gap we face. To get there, we sure could use your support as a donor or a volunteer. To get involved, please go to beyonddementiacoalition.org. All donations are tax deductible, and be sure to subscribe to our mailing list to receive our monthly newsletter in your inbox, where we'll share new podcasts, fact sheets, webinars, blogs, and other dementia-related content. This is Dementia Air. See the person beyond the disease.